Hi, my name is Greg Formosa, and I'm a PhD student at CU-Boulder working in the Advanced Medical Technologies lab. Today I'll be talking a little bit about my work with robotic endoscopy, and specifically the design and surgical evaluation of a new mobile colonoscopy robot. But first, let's talk a little bit about what motivates this research.
Colorectal cancers are the second most deadly cancers worldwide and the fourth most diagnosed. They begin as non-cancerous polyps or growths within the human colon or rectum, and if not treated can metastasize and become fatal. However, these cancerous growths can be easily treated and removed if diagnosed early. In fact, the disease is much more survivable than other forms of cancer, with over 80% 5-year survival rates when caught at early stages. However, only about a third of these diagnoses are made at these stages, much in part due to the low screening rates. This leads to over 600,000 deaths worldwide every year. Many studies have cited that increases in these screening rates could drastically reduce the fatality rates of colorectal cancers. But first we must ask, what are some causes for these low screening rates, or what are the barriers preventing screenings to improve early stage diagnoses? Although there are several means of detecting colon cancer, none can really supplant the diagnosis and treatment capabilities of the traditional colonoscopy. During this procedure, an endoscope as seen here is inserted through the anus and into the rectum and is manually pushed throughout the colon. The physician will progress the scope until it reaches the cecum, or the end of the large intestine, and then will begin inspecting the colon while withdrawing the scope. While many factors make the colonoscopy a technically challenging procedure, the inherent difficulty in pushing a semi-rigid scope through a flexible three-dimensional colon is perhaps the most significant problem. Distension of the colon walls can lead to patient pain and discomfort, or even perforation and the need for emergency surgery in extreme cases. Other procedural technicalities, such as looping of the scope, can hinder progress through the colon, leading to incomplete inspections. Additionally, these issues lead to the increased preference for those screened to use sedation, which increases the procedural cost, time, and the need for an operating room as opposed to a less clinical setting, such as a medical office. There are other less invasive methods for detecting colon cancer, but none of these can offer the accuracy or treatment and interventional capabilities of the endoscopic colonoscopy. We believe that implementing robotics can reduce this invasiveness of the colonoscopy while still offering the same accuracy and interventional capabilities of an endoscope. Within this robotics realm, we believe that the best option for this is a self-propelled robotic capsule endoscope, or RCE. Thus, we have created the Endoculus. The Endoculus is a robotic capsule endoscope with all the traditional tools of a colonoscope, such as irrigation, suction, illumination, vision, and a tool port for various interventional instruments. The device is approximately the size of a 9-volt battery and can be naturally inserted into the body through the anus and then remotely self-propelled by micropattern treads to alleviate the concerns of distension and looping that occur when manually pushing an endoscope. These micropattern tracks are specifically designed by our lab for high traction and minimal adhesion on the slippery fluid-coated colon tissue, and are continuing to be researched. More information about the design and mechanics of these pillars can be found at the AMTL's website shown below. In addition to the diagnostic and interventional capabilities of the Endoculus, it also incorporates a number of electronic sensing solutions, such as a high-definition camera, a 3-degree of freedom magnetometer and a 6-degree of freedom gyroscopic IMU, motor encoders, and current sensors for motor feedback control. These visual, inertial, and mechanical sensing solutions will allow for the development of semi or even fully autonomous control of the device, which can augment physician capabilities and lead to a reduction in the technicality of endoscopic procedures overall. Now let's take a quick look at how the device operates before diving into the novel design process. Each half of the device is driven by a gear-reduced miniature DC motor attached to a custom double worm screw seen here in the center that was designed with both right-hand and left-hand pitches to allow for significantly reduced gear forces and to improve drivetrain efficiency. This double worm transfers power to the 2 worm gears, which rotate a timing belt-style pulley driving the treads above and below the device. The Endoculus operates with 2 degrees of freedom by driving each half of the device independently, allowing for the tank-like skid steering motion. The treads were intentionally put at angles to allow for better contact on the non-planar surfaces of the colon. In order to drive the top and bottom treads in the same direction, which may be necessary for propelling through a collapsed lumen, an idler gear was added to the top side. The device was novelly designed by a combination of design and performance constraints with full drivetrain parameterization, allowing for the geometries of the device to be minimized with an optimization routine. First, the worm gear interactions were chosen to minimize the space claim of the device. Looking at one quadrant of this device, all components, including gear geometries not shown, were parameterized as variables. In industry, gear tooth parameterization is generally not done because gears are designed for discrete, off-the-shelf sizes or for specific manufacturing methods. However, with the advent of 3D printing techniques, gears can be printed in any geometry by fully varying the parameters such as tooth module and pressure angle. We then limited our design space with geometric constraints, such as interferences, mechanical constraints, such as gear tooth bending, and design criterion, such as top speed and rim pull. Combining our parameters with these constraints, we can optimally minimize the size of the device by setting our cost function as the width or height of these geometries. This was performed with a nonlinear generalized reduced gradient optimization routine, and resulted in a device width and height of only 30 mm by 23 mm, while still meeting all design constraints such as a 2x safety factor for gear bending stress. This design also allowed for speeds above 40 mm per second, almost twice as fast as the fastest recorded robotic capsule endoscopes in research. Additionally, it's important to note that none of these RCEs listed here have the interventional capabilities that the Endoculus does. In addition to its rapid locomotion, the Endoculus was capable of an impressive rim pull capacity of 12 newtons, or about 3 force pounds, which is almost 30 times the device's weight. This will prove useful for locomotion up large grades or even pulling the device's tether throughout the colon. To incorporate traditional endoscopy tools and abilities, the Endoculus can be connected to a water line for irrigation and cleaning, an air line for suction and insufflation, and a tool line for various interventional instruments such as biopsy forceps, polypectomy snares, or tattooing needles. Because these lines are required for the interventional colonoscopy anyways, a flexible electronic wiring harness was also used to power and control the device remotely from an external control PCB. For initial testing, the Endoculus was manually controlled with a USB gaming controller through a computer interface. However, it can also be wirelessly controlled through the Wi-Fi-enabled Photon microcontroller. The setup was then tested in vivo with an anesthetized porcine subject, and ex vivo with the same subject's excised colon. For in vivo testing, seen here on the left, the Endoculus was quite easily inserted rectally into the subject without any harm or negative effect to the patient. It showed successful use of all tools such as illumination, irrigation, cleaning, local insufflation, and tissue biopsy as just seen here. Locomotion was tested in vivo, however, due to the constrictive size of the pig colon, that's about half the diameter of human colons, as well as the spiraling nature of the porcine intestinal tract, it was unable to traverse more than a handful of centimeters during live animal testing. However, ex vivo, as seen here on the right, where the colon could be safely expanded to a larger diameter for more similar comparison to the human colon, it showed successful locomotion of up to 40 mm per second in both insufflated and collapsed scenarios, even traversing over obstacles such as large haustral folds or the muscular ridges within the colon, as seen here. During this testing, it was also remotely steered in 2 degrees of freedom within the excised colon, making turns to inspect the sides of the mucosal walls. This work has shown a novel optimization-based design of the Endoculus, a robotic capsule endoscope with all the capabilities of a traditional endoscope, yet actively propelled and housing various electronic sensing solutions. We believe the Endoculus's design process is of importance to the medical robotics community, especially the small space claim double worm drive that improves drivetrain efficiencies, as well as the drivetrain parameterization and optimization used to minimize the device's size. In vivo was naturally inserted into the porcine colon, was operated without damage to the subject or the device, improved functionality of all traditional endoscopic features. Ex vivo, the micropillar treads gained consistent traction in a human-sized lumen, steered in 2 degrees of freedom to inspect the mucosa and traverse large haustral folds, and reached speeds of up to 40 mm per second with strong pulling capacity. Since this work has been published, we have worked towards more complex autonomy tasks, such as navigation, localization, and mapping, as seen here, and even autonomous endoscopic intervention. Future work will include continuing in vivo testing with various endoscopists and physicians to improve functionality of the device and compare performance with traditional endoscopy.
Thank you all for taking the time to view this virtual ICRA 2020 conference proceeding. If you have any questions, feel free to contact me at the email below, or check out more of our exciting research at the AMTL's website, amtl.colorado.edu. Thanks.